Okay, great. Well, hello, everyone. I'm not sure if Patty actually introduced me or not. I was watching her earlier session. My name's Mike Policar. I'm an obstetrician gynecologist, recently retired from University of California, San Francisco, OBGYN department. And now I spend most of my time as the clinical fellow for NIFRA, the National Family Planning and Reproductive Health Association, and as a senior medical advisor to the California State Office of Family Planning. So I'm going to spend 10 minutes discussing with you the whole suite of CDC family planning guidelines, something that is incredibly important for us as clinicians, and something I can give you a little bit of an insider's view of, given the fact that I was a member of the expert panels at the CDC that did the medical eligibility criteria, the selected practice recommendations, and the quality family planning guidelines. Next slide. Great. So we'll start with the MEC, and let me remind you that these actually didn't start with the Centers for Disease Control in the United States. They actually started with the World Health Organization, well over 20 years ago, as a way of developing evidence-based contraceptive guidelines, particularly for less developed countries. But one of the things that the WHO had intended was for countries with more developed health systems like the UK and Canada and the United States to develop their own version of these based on our own health delivery system in the United States. So the first time we saw the medical eligibility criteria in the United States was in 2012, and then they were updated again in 2016. This is the most recent reference. I've also been asked questions about when will we see the next version of the MEC, and I had a discussion with Kate Curtis about that a few days ago. Probably not for a little while. They're going to await the WHO to update their medical eligibility criteria, and then the CDC will start on the next version for us. Next. Now, the large majority of you know exactly how this works, that basically what the MEC does is to look at, number one, a variety of different types of contraceptives, 6 or 7 groupings altogether, and then over 60 different kinds of medical conditions. And basically they refer to the safety of using a particular method of contraception in a person who has a specific either chronic medical condition or based on their age or other considerations. And remember that those recommendations fall into 4 categories, category 1 through 4. So if it's a 1, basically there's no restriction on the use of the method for a person who has a particular condition, let's say controlled hypertension, for example. A 2 means that it's still safe to do it, but we do need to follow up those patients a little bit more closely. That might be a diabetic who's using oral medications, who wants to use a combined hormonal contraceptive. That's fine, as long as we do more frequent follow-up. A 3 is when there's starting to be balance between the benefit and the risk of the method, but the person can still use that method because it's safer than being pregnant. And then number 4, and of course there are very few 4s, is that the risk of using the method in a particular patient because of their underlying condition is so high that they simply should not use the method. But one of the things I want to mention before we leave this slide is that a 3 is not equal to a 4. And what we've seen over the years in many clinics is a rule which says if there's a 3 or a 4 combination, that, let's say, a nurse practitioner has to get approval from the medical director in that circumstance. I think that's way too conservative. The point is that given the choice between a 2 and a 3, we'd always rather go in the direction of the 2. But there are some circumstances where the only thing that's available to a patient is the method she's chosen, and it fits into category 3, and it's still safer than being pregnant for her to use that method, and it's acceptable, just a closer follow-up. Next slide. Okay, so I'll show you some examples of how this works in the medical eligibility criteria. Here's the one for diabetes. So you'll see across the top, the various columns are the categories of contraceptives. The first being combined hormonal contraceptives, OC, patch, and ring, progestin-only pills, DMPA, implants, and then the 2 categories of IUDs. Now, each of the lines then will tell you what the categories are for various kinds of conditions. The first being a history of gestational diabetes, where any of the methods are considered to be safe. The next is a person, let's say, with type 2 diabetes who does not have vascular disease in their eyes or their kidneys or peripheral vascular disease. Doesn't matter whether they're on insulin or not on insulin. Every one of the methods, including the estrogen-containing methods, is considered to be a 2, which means more frequent follow-up. And then the only time we see 3s and 4s is with estrogen-containing methods for people who do have vascular disease, kidney problems, eye problems, peripheral neuropathy problems, or a person who's had other vascular disease like a heart attack, or they've had diabetes longer than 20 years. And in that circumstance, we'd rather use one of the other methods. So again, just intended to be an example of what these tables look like. Next. The next table, there we go, is one that was quite controversial, and that is for various kinds of headaches. The first line is non-migranous headaches, things like tension headaches or seasonal allergy headaches. Every method is considered to be a 1. With migraine headaches, as long as a person does not have an aura before their headache starts, virtually all the methods are 1s or 2s. The only 4 that you see is in a person who has migraine with aura, that they should stay away from using an estrogen-containing method like pill patch or ring. Next slide. Okay, so that tells you a little bit about the MEC. Its companion is the selected practice recommendations, initially published in 2013 and then upgraded in updated, I should say, in 2016. These guidelines are organized by chapters for each method of contraception. So you'll see a chapter on combined hormonal contraception, another one on contraceptive implants, another one on injectables like DMPA, another one on IUDs, for example. And in each of the chapters, lots of advice about how to maximize the efficacy in the use of those respective methods. Next slide. Now, when we last met at the CDC to update both the MEC and the selected practice recommendations, these are the kinds of things that we looked at. First off, there are a whole variety of chronic medical conditions that are in the original medical eligibility criteria, but we want to keep adding new ones. So we added things like contraception in people with cystic fibrosis or people who have multiple sclerosis. We greatly expanded the section on drug interactions, particularly with SSRI, antidepressant medications, and things like St. John's wort, which people use for depression, purchased over the counter. A whole new section on uloprostal acetate, which is the ELA emergency contraceptive pill, in the selected practice recommendations. And then we also did major revisions for migraine headaches, women using antiretroviral therapy if they have HIV. And we spent a whole day one day out of 3 talking about the section on breastfeeding and progestin-only contraception in the medical eligibility criteria. So I bring this up only to say that they are in continuous evolution, not only based on what the evidence says, we're always looking at new good quality articles and meta-analyses, but the topics continue to evolve as well. Next slide. Okay, and I'm sure that you all know this, or virtually all of you, and that is that the best way to access these guidelines is to download the app for the medical eligibility criteria and the selected practice recommendations. Whether you use an Apple device or an Android device, all you do is go to, give me the next click. I think it'll say down there what on the slide. Oh, well, just go to the Apple Store, type in, there we go, Contraception, CDC, and you will see this logo and be able to download the app. And it's really well done because it does sort of coordinate the sections that are on the MEC and the selected practice recommendation. Every clinician who does family planning services, whether you're a reproductive health care provider or a primary care provider, really should have this at your fingertips. If it were up to me, I'd say that it should be a national quality metric, just to make sure that as a clinician doing family planning services, you have this available to you. That's my opinion. It's not a national guideline at this point. Next slide. Now, what I want to do is to go on to say that when we think about these guidelines from the Centers for Disease Control, it's not just the MEC and the SBR. There is a whole suite of evidence-based guidelines that are available. And I'll tell you a little bit about each one on the clock face. So next, we're going to animate this a little bit. So over at 9 o'clock, we have the 2 contraception guidelines. Next, so the MEC and the SBR that you know about now. Click twice. So down at 6 o'clock, we have the guidelines that are related to both STD treatment as well as HIV management. And I want to remind you that we've all been waiting anxiously for the next version of the Cdc Std Treatment Guidelines. They were supposed to be published in 2019, then 2020. The most recent update I got is that they should be published in MMWR by the CDC in the next month or two. They will actually have a new name. They'll be called the Sexually Transmitted Infection, STI, Treatment Guidelines 2021. So keep your eyes open for that. I've seen an advanced copy, and I'll tell you there are some quite significant changes, particularly in the treatment of gonorrhea, chlamydia, new section on mycoplasma genitalium, and some other topics that are important. Next to that are the HIV guidelines, most recently updated in 2016. Next. Over at 3 o'clock, we have what originally were called preconception guidelines. They're now called pre-pregnancy guidelines that are issued by the CDC. They're a little out of date, and the American College of Obstetricians and Gynecologists has published just within the last year or two a new guideline, a committee opinion that has to do with pre-pregnancy counseling and pre-pregnancy care that I think is far more up to date. And then last click up at the top are the Achieving Pregnancy Guidelines. And CDC did not do their own version of guidelines about how to become pregnant, guidelines for female infertility and male infertility. Instead, we rely on the guidelines of the ASRM, which stands for the American Society of Reproductive Medicine. That's sort of the trade group of the infertility specialists, including the ones that do the high-tech infertility work like IVF and others. But in their journal, which is called Fertility and Sterility, they recently have updated their guidelines about basic infertility workups for females and males, in addition to a really nice article about the advice we give people who are trying to get pregnant and how to achieve pregnancy. Next. Now, the last thing to mention is the center, okay? And that is the yellow area, which is referred to as the QFP, standing for Quality Family Planning Guidelines. This is the CDC guideline done in concert with the Office of Population Affairs, the program that runs Title X. This kind of brings everything together. So next slide. The QFP was last updated in 2014. Hopefully we'll see a new version of it in the next year or two. But basically what the QFP does is evidence-based guidelines about topics related to family planning that are not covered by the other 5 or 6 guidelines that we just mentioned. So it has sections on pregnancy testing and counseling, section on advice to achieve pregnancy, basic infertility for both males and females, pre-pregnancy health, preventive health screening of men and women, so what should go into a well woman or a well male sort of checkup visit, and then a nice chapter on contraceptive counseling, at least what was the state of art in 2014. What you just heard from Patty and Jolie is far more up to date than what's in that section of the QFP, but it's still a good starting point. Next slide. Almost there. There we go. So what's the big deal about the QFP? The QFP is, oops, go back one. The QFP is the sort of the most unappreciated, I think, of all the guidelines. But it has very, very helpful information. So number one is the fact that it ties together the CDC suite of the other family planning guidelines that I just mentioned. Somehow it brings together the MEC, the SPR, the pre-pregnancy guidelines, the STD guidelines, and so on, and then fills in the gap between them. Number two is the fact that it prioritizes the core content of contraceptive services. And that part's really important. And what I mean by that is that we all know that primary care providers, that let's say are family medicine providers or internal medicine providers, do some amount of contraceptive work. But there had never been a guideline which says, here's the minimum of what you're expected to do. And that is contained in the Quality Family Planning Guidelines, sort of the floor of expectations. And then in addition, many of us in family planning clinics not only do family planning, but we do sort of broad, comprehensive, well-person care. And then this guideline also defines what some of those topics should be, things like healthy diet and exercise and a variety of other things. It describes state-of-the-art contraceptive counseling, at least as of the time it was published, has a very good section on male family planning services. So if that's something you're doing in your clinic, it may have helpful advice for you. Last slide. And what I want to do is just basically summarize for you the QFP in 4 sound bites. So what it does is to define the scope of family planning services. And as you just heard in the talk about PATH, that family planning is not always preventing pregnancy or delaying pregnancy. Oftentimes it's, I want to get pregnant, and helping people to be able to do that. And I know that the Office of Population Affairs and the whole objective of the Title X program is not only to help people prevent or delay pregnancy, but also to achieve pregnancy. And that's something that we need to be in a position to help people with. Number two, it acknowledges the fact that the focus of the family planning visit has been changing. It used to be that most of what we did before the pandemic was done in the exam room. But over the last decade, we've been kind of leaving the exam room with family planning services and more going in the direction of the consultation room, doing exactly the kind of counseling that Patty and Jolie were just talking about, not only with PATH, but a variety of sort of shared decision-making conversations that we have with people about their choice of method, if they want a method at all. And there's less to check for in the exam room and a lot more to be able to do now in having conversations with people. A part of that is the third bullet, that we've moved away from directive counseling, which is as a clinician giving people advice about what they should use. We went through a phase of what was called informed care, where we told people about everything on the whole menu. And now finally we're in the position of not only discussing things like pregnancy intentions with the PATH questions, but also having discussions that are based on shared decision making. And then finally, the QFP adds to the content of clinical care with the 5 existing CDC guidelines that I mentioned, and then filling the gaps in those that aren't there. So as we do our case studies after the break, we'll be relying on particularly the MEC in a number of cases, and hopefully during the break, if you don't have it already, you will download it into your cell phone and you'll have it available to you. Thanks.